I'm going to show you how our new fluid prescribing power plans allow you to prescribe in line with NICE Clinical Guideline 174 for adults in hospital.
And we're going to work our way through the algorithm, starting with fluid resuscitation.
This is what NICE has to say about fluid resuscitation. What we've done is converted that into a practical prescribing power plan.
So from the blue side menu, click on the plus add for request care plans and type fluid. You'll see a variety there, and we'll look for fluid resuscitation. Two options, plasmolite and sodium chloride. Sodium chloride should only be used in the emergency department when concomitant antibiotics are going to be given in order that the two fluids are compatible. Once the patient's weight is documented, the doses will auto-populate. Anyone over 50 kilos will have a 500 ml dose of either plasmolite or sodium chloride. Anyone with comorbidities of chronic kidney disease or congestive cardiac failure will have a start dose of 250 mils. So let's pick plasmolite. Order that. There's nothing else to change. Sign and go. The important thing is you reassess the patient once they've had the dose delivered. Up to 3 more doses can be administered in a 24-hour period before senior clinician input is required to determine if different treatment is required. Let's have a look at fluid redistribution, which is the next in the NICE algorithm. I'm in fluid and look for redistribution. Now this comes pre-ticked because there's only one fluid choice available, and that's plasmolite. There's information about how to calculate the dose, and it's repeated in the order. So if we click more, details required. You'll need to read this bit here, because it depends on the illness severity of the patient, how much fluid you will give before you reassess. It pulls through the patient's weight, so you can work out the volume or the rate required. So let's go for 1 mil per kilogram per hour. So that would be 74 mils per hour. And I would want to recess after, well, somewhere between 4 and 8 hours, but let's go for 6 hours. And that calculates the dose volume. That's the volume of the dose to be delivered in the infusion period. The only other thing that needs adding in is the number of bags required. And for something less than a litre, you're going to need 1 bag. So let's put a duration of 1. Sign that. And that's that done.
Fluid replacement is next and sits in the same section of the NICE algorithm.
And in order to understand how much fluid is going to be required to be replaced, you need to look at what has been lost in the last 24 hours, or what you predict is going to be lost in the forthcoming 24 hours. And you get that from the patient's fluid balance chart. So you will need to look and see what the overall losses and inputs were over the last 24 hours, determine what volume you then need to input. Once you know that, you can go to the request care plans plus add, type in fluid, replacement this time. Now you can see there's a choice of fluids of either plasmolite or sodium chloride. The choice is determined by where the losses of fluid are coming from. If they are non-gastric, you will use plasmolite, which is a balanced electrolyte fluid. If the losses are gastric, then choose sodium chloride, because you also need to replace the chlorides being lost from the hydrochloric acid in the stomach. So let's go for plasmolite again. 3 missing details this time. So the first one thing is, what's the dose volume? How much is being lost, or how much do you want to replace? So let's say it's 2,200 mils, round to the nearest 100. It's over a 24-hour period, so it works out the hourly rate. It's still asking for a number of bags required. Now, these are real bags, but in Millennium, they also are what we call virtual bags. So 2,200 mils is going to require 3 bags. Only 2 and a bit will actually be used. The final step in NICE's fluid guidance is routine maintenance. Now, in this case, we've got a choice of 3 different fluids and 2 different dosing regimens. If people's electrolytes are normal, you'd use Maintenolite, which provides a balanced amount of electrolytes to give the daily amount of potassium and sodium and water. If they are hyperkalemic, then you should be following the hyperkalemia guidelines. But if at risk of hyperkalemia, then you would use a bag without any potassium in. If they're hypokalemic, you should use the hypokalemia guidelines, but if they're at risk of it, they're heading down, then we'd want to put extra potassium in. This one's got 40 millimoles per litre in. If they have CKD, they're frail, they have CCF, or they're malnourished or at risk of a refeeding syndrome, then we'd use the bottom portion, which doses at 20 mils per kilogram per day of water, as opposed to 25 mils per kilogram per day. So let's go with Maintenlite, and we'll go with the bottom option here. Nothing else to change because the volume is pre-filled with knowledge of the patient's weight. The only thing to add would be if you know the intravenous antibiotics are being given, for example, and there is an associated volume with that, so amoxicillin, metronidazole, gentamicin, if all given as an infusion, would have an extra 700 mils of fluid in there. You'd need to remove that volume from the total dose, otherwise you're going to have fluid creep and more fluid going in. Let's assume there's nothing else going on. There's no interaction checking with Maintenlite, so we can click OK for that. There's nothing else to change. We sign it and go.
And that is how we prescribe in line with NICE. We choose the indication, then the fluid, then the volume, then the duration, and finally the reassessment period. Thank you for watching. See you next time.